are going to get, I have to remember this. So if anyone sees that we're not using these, please let us know. So welcome. This is our first TGCT track for the SPAGN conference. Last year, I gave a talk. Emanuela was there. A few other people gave talks, and it really caught fire. And so we're hoping to make this a more regular thing. So thank you all for coming, and I will hand it over to Emanuela Palmerini, who is an amazing medical oncologist who will give you a talk about differentiating the differences between localized and diffuse to TGCT. So I'll give you.
Thank you. Thank you, Sydney. And thank everybody for being here. I already met a lot of patients around the world, and actually I would like this to be very informal, and everybody can jump in with their experience, which I think will guide us how to serve best this journey in this weird, we can say weird disease. We will see. But first of all, differentiated in between localized and diffuse. So I'm a medical oncologist at Istituto Ortopedico Rizzoli, and till 2015, actually, I never heard about such a disease when Bob Mackie told me, you have probably the largest series, and you should get to see how this disease is managed. The reason I didn't know about it, because it is a benign tumor, so usually benign tumor are treated with surgery only, and so by surgeon only. But as you know, this disease, it's locally aggressive, and now we have several ways to treat it, and Giacomo will let us know. The problem with this disease, it starts from the naming. So since 2012, but this is the classification from 2020, the name has been changed. So pigmented villonodular synovitis should not be used. I keep underscoring it, but I have also here an example of a patient from Rome, and a report 2023 is still according to this definition. The reason is that it's a real tumor. Tenosynovial giant cell tumor is much more appropriate in that concern. There are two clinical entities, and maybe later we'll come up with a consensus we wrote all together with Sydney and the patient, sarcoma patient. So the one of the objective of this consensus was to explain what is clear, and the name nodular or localized was very well described to indicate the disease which is well circumscribed. It's very most frequent, 10 per million per person a year, and usually it's around 2 centimeters or so, but there are also larger nodules. While diffuse is usually with a permeative pattern and locally aggressive, and usually destroy all the eventually the intraarticular space and the bone, and it's rarer. 4.1, and then there are the digits, which is not in this classification, which is even more frequent. It's like 29 per million. And with this incident, there is a higher proportion of localized cases, which account to 15 new cases in United States. But the number of the patient really affected to this disease is much higher, because this disease has a prevalence which is very, very important due to the fact that this disease is a chronic disease as diabetes. So the chronicity is one of the most important things, and localized and diffuse, of course, entity, they really have different risk. Localized recurrence rate is up to 16%, while diffuse is up to 55 or even 70 in some of the series. Histologically, they both contain these four cellular types. So giant cell, which is everybody would also, a non-pathologist like me would recognize, is this funny. Yeah. Okay. Is it funny cells with multi-nuclei, like 100 sometimes, and then there are foamy macrophage, which has the whitish cell, and then the siderophage, which brownie, and the mononuclear cell, which is more monotonous and small nuclei. And the hemocysteine deposits are pretty characteristic, and from there the name pigmented. And this can be found both in localized TGCT, in which we can find the most hyalinized collagenous stromas, and also these labrid cells, which are where the hemosiderin forms like a rim, while the diffuse type is most often positive to clustering in immunohistochemistry, and as more often mononuclear cells, like in that picture. But the cytogenetically they're identical. They both come from this CS1 COL6A3 fusion and overexpression that was discovered back in 1994, and from there this pathogenetic loop was discovered, which affects the patient with TGCT, which is links the tumoral cells with the stromal cells. So the problem that patient report are often linked to the edema, which is caused by the inflammatory changes. But there are several other translocations that can be found in this disease, and in this paper of 18 samples where sequencing and novel fusion were discovered, and also some mutation like CBL, which might be prognostic, as you can see in that graph on about 34 patients. Okay, thank you. Okay. That's easier. And then the symptoms you can teach me. They're usually they're very swelling, pain, but the most important things, and I keep saying it also to this meeting, is that people come to compromise with their physical activities, and people actually ages earlier because they just stop doing what once is supposed to do to keep itself healthier. So I think we should try a way to counteract this not healthy lifestyle problem. And radiologically, it's very clearly different from localized and diffuse, as we can say from MRI, CT scan, but sometimes also from X-ray. And there are several cases that shows us how these diseases eventually destroy the bone with important erosive changes that results in non-treated disease. On MRI, we can also see the hemosiderin, and there is this GRE image, which is pretty characteristic. Usually, the disease is positive to the contrast media, but actually, as you can see in this T1, the lesions are very dark. So I keep saying that we don't necessarily need the contrast medium because you can see the nodule pretty well also without it. And the Leiden group was able to classify the severity of the disease by MRI. As you can see, the diffuse type they comes as intra or extra articular, and based on the involvement of ligaments, a classification of severely diffuse, mild diffuse was done, and of course every risk group harbored different relapse-free survival. So of course, if you have a localized disease, your relapse rate is much much lower. Diffuse severe, which is more than 60% of the cases relapse. So, as I said, Bob Mackie suggested to collect the cases before the tyrosine kinase inhibitor area in order to describe how the disease was, because not being a tumor, nobody actually would know. So as I say that the bone involvement is often present in 18% in this series, where the most involved site was the knee, and the female were the most affected. And in this series, 70% had the diffuse type and 31 localized. We decided to collect only cases at new diagnosis or first relapse in order to describe the same population. And what we got that the local recurrence is high, 28% of our patient relapsed, and diffuse type up to 36%. And the most sad is that people relapse also up to 5 years in 40% of the cases. And of course, the one of the most important prognostic factor is to have a diffuse type as compared to localized, but also to have a relapse. So the point is, if you are badly treated and you relapse, then your likelihood of relapsing is much, much higher, like 77% as compared to 12%. And oh, I don't know what is. It should be in the way around. But anyhow, with this within this project, we collected the effort of more 31 center to study, of course, the disease, in particularly also the quality of life and the economic burden. And these two publications came up on localized and diffuse. So on 900 patients with localized, we confirmed the recurrent rates vary around 10%, and the diffuse type we observed that about 10-15% they underwent arthroscopic synoviectomy, but in 6% prosthesis was necessary, and some patients also was amputated, very few likely, and the recurrence rate was 44%. Again, this curve that patient after relapse, the yellow line, have a very much higher probability to relapse again. And this study also showed that overall there is no difference in between open to arthroscopic, but in the new diagnosis in the knee, open seems better. So based on this retrospective study, we declare that the surgery alone cannot be a good way to treat patient with diffuse TGCT, and we tried also to look the problem also from quality of life and socioeconomic burden with this other part of the project, prospective collection of patient reported outcomes. We were able to have 155 patients, and in this publication, I didn't know that, but the healthy population usually has a mean health utility of about 0.83, and the TGCT decrease it to 0.75. So the quality of life is worse, and this is another publication which looks at this quality of life changes over time. So after 1 year and after 2 years, and we observe that people that has more pain, usually it's more likely to change its treatment, and very similarly in a patient in which the quality of life decreases, the treatment is changed. So to conclude with some clinical scenario, I think that to understand this diffuse or localized disease, not only it's important the histology and the MRI, but also the age and the objective of each one of our patients. For example, being a young mom with this diffuse, it's a very important limitation to do daily activity. And similarly, having a small nodular TGCT, if I'm a piano player, would be affecting as well my quality of life, and maybe doing surgery in a patient like this would be suboptimal as compared to a systemic treatment, in order not to risk surgical morbidity in a professional piano player. While maybe a 70-year-old woman that works in the outskirts would live differently in this disease, and would accept some minor limitation, but as said before, the problem of this disease, the chronicity and the relapse. I always talk about this mom. She is the mom of a medical student, and not only she was operated, I don't know, 7-8 times, but as you can see in this CT scan, the disease MRI, the disease came back also around the prosthesis. So there is no actually surgery that really spare you from recurrence from this tumor. And the last, when to use systemic treatment. I'm very glad to tell the story of this young bartender, which was never operated on TGCT, but came to our center with this very bad MRI, and my orthopedics oncologists were like, we don't want to operate on him, because maybe with the systemic treatment he can have more success, and the patient had a complete response. So without risking morbidity of the surgery, he was able to have a normal life and go back to work. And so last, I really want to ask to you today if we really need this classification, because I think it's not more important of the classification on diffuse and nodular is how the quality of life and the symptoms are affecting the specific patient in that specific age. And in this concern, with the Leiden group, we conducted this study to see if we can even observe some of the patient with it's a small series, just 59 patients with diffuse only TGCT. And the study concluded that active surveillance can also be adequate in selected cases, and specifically here, 2/3 of the patient remained progression-free, although 1 out of 5 patients developed secondary osteoarthritis. So in the future, we have to consider all these this feature in order to change our decisional path. So in the past, like in 2015, localized disease, just surgery, diffuse disease, surgery when it was possible, unresectable systemic treatments maybe. But I think that now we have enough information to change our flow chart, the seasonal flow chart. So if you have we don't even know need to ask if it's localized, but the symptomatic is I think on top of our priorities. So if it's symptomatic, it's not symptomatic, active surveillance might be possible, while in case of symptomatic disease, we need to ask ourselves if the morbidity with the surgery, and also if the surgery is able to remove all the disease. And in case the morbidity is high, we might consider upfront inhibitors or neoadjuvant, and in case of complete response, we can go for drug holiday or rechallenge in case of symptomatic progression, or in case of partial responses, to do the surgery after TKIs. So this is just a proposal, because I think that the real strategy has been to discuss in between oncologists, of course, surgeon, and of course patients. And so I think that localized and diffuse TGCT are very similar under the microscope and share common pathogenesis, but looking better, they are like very different as in the picture of the vest. But it's very important that we refer all our patients to high load center for this disease. And I thank Sydney, because she's really incredible. She's been able to refer to me patients from my own city. So a patient from Bologna ask in United States advice for us. And of course all this change of perspective need that we discuss at the multidisciplinary level, not only the very bad relapse case, but each case for the very beginning, in order to spare morbidity of post surgical changes, but also morbidity of a long lasting disease. And I really thank you for being here today to discuss your own story with us. Thank you.
Thank you. Dr. Palmerini. Thank you so much. And we will have a Q&A after that'll involve Dr. Palmerini. So please feel free to save your questions for that session. And we are super excited to have her, as well as all of the other doctors who are spending their time here.